All right, so this will be the end or the last of the three medication lectures. So the first one I'm going to go through is pralidoxime and atropine. In parentheses is duodote with a Mark 1 kit, which are basically two auto injectors that you can use to give these medications. I'm including a picture of the neuromuscular junction here because that's important for understanding how these medications work. So they, these are used for usually organophosphate exposure or poisoning, which are basically, insecticides or pesticides that work to, they work on acetylcholine, which is important for the neuromuscular junction and just in general nervous system functioning. And so, these two drugs have two different. Typical organophosphates are inhibiting acetylcholine esterase, which breaks down acetylcholine in the synaptic cleft, which means too much is left and there's excessive signaling there. So you've got these two drugs, atropine, which basically blocks the acetylcholine receptor, and then pralidoxime, which removes that antagonist, removes that organic phosphate, and then reactivates that enzyme to start breaking down acetylcholine and removing it from the synapse. I edited this slide, but one of the things I wanted to have on here is a good acronym, SLUDGEM, which is used as a way of identifying organophosphate exposure. And it's just basically excessive parasympathetic nervous system activation. So you'd see things like salivation, how the acronym follows: salivation, lacrimation, which is tears, urination, more, excessive frequency, defecation, same thing. Gastrointestinal irritation, that could be things like, GERD, heartburn, reflux, things like that. Could have nausea and vomiting. Emesis, which is nausea, and then meiosis or muscle twitching. So meiosis is like pupil constriction, so pupil constriction, or like the muscle twitching, and that's why I included the neuromuscular junction here, was because that's one of the ways that acetylcholine acts. In terms of contraindications, there aren't really any. This drug is super important to help prevent organophosphate poisoning, so none of the contraindications really outweigh what the benefits are. Now, when it comes to, oh man, I forgot to add a animation there. Okay, when it comes to dosing, we've got two different drugs, so two different dosages to go through. Pralidoxime is the simplest. Both of these can be given IV, IO, IM, anything to get into the vasculature, really. But for pralidoxime, in adults, you'd have 600 milligrams. And for pediatrics, it's weight-based, and you can go anywhere from 15 to 25 milligrams per kilogram. So there's some discretion there based on the amount of organophosphate, that a patient has been exposed to. For atropine, adults is 2 milligrams. But then for pediatrics, it starts, it depends on their weight. So if they're less than 40 pounds, we're only going to give them 0.5 milligrams. If they're 40 to 90 pounds, we'll give them 1 milligram. If they're greater than 90 pounds, we give them 2 milligrams. So, greater than 90 pounds, you're basically just considered an adult. That's like adult weight, where you could probably, it's assumed that you can metabolize this drug the way an adult would, and that's why you get the full dose. So we will go on to the next drug, which is calgonate. So it's a calcium paste. So it's not just calcium. It's calcium and gluconate, which is basically just used as a anion so that the calcium can stay stable in solution. But these are basically used for exposure to hydrofluoric acid, which is usually abbreviated HF. And in particular, the damage here is the F- anion, because F- is so small and so negative, it's so electronegative. When it gets into cells, it can form these complexes with things like magnesium, potassium, other ions, and just basically create these insoluble crystals that will kill cells if they have to, one of the things that you need to, as a provider, the way that we might be able to check for hypo or hypercalcemia is by looking at a 12 lead. And I have some a little bit about that. But if you look at if you look at this segment here on the on the normal side, we've got a normal QT segment after the depolarization, and that's the repolarization of the ventricles. For hypercalcemia, that distance decreases, and for hypocalcemia, that distance increases. So basically what's happening here is that and this picture is kind of blurry, but in the ventricular cardiomyocytes, that action potential has a plateau phase, which is caused by calcium flowing through. It's a calcium influx that's balancing the potassium efflux that's leaving the cell. So that leads to a longer depolarization phase, which is why we get that change in the 12 lead. So it's important to try and get that on. And, they might also present with cardiac problems anyway, so that could be a good idea. In terms of indications and dosing, like I was saying, it's exposure to hydrofluoric acid. It's a topical gel. I had a bit of trouble finding specific indications, but the concentrations range from anywhere from 2.5%. Actually, technically they go down to 1%, and then all the way up at 10, but 2.5 tends to be the most standard. In terms of contraindications, the only two are really hypercalcemia, and you're not going to give this to the eye. So even if someone's had an eye exposure to hydrofluoric acid, you would still just rather rinse that with water. You can use a nasal cannula or something and irrigate that, but you don't want to apply it to the eye because it will probably just cause more irritation than it fixes. Man, I'm slacking with the animations today. All right, so the next one is cefazolin, also known as Ansef. This is just an antibiotic. We're basically using this when we see anything related to open wounds, fractures, amputations, anything that's exposing our the inside of our body, not the GI tract, but anything that's still the internal environment to potential bacterial infections. So you've got open trauma, open fractures, things like that. You want to give this. I think one of the main things to know is that this is not considered a primary treatment. We're not doing this before we're stopping bleeding. We're not doing this before we're dealing with airway and bleeding and stuff like that. So, this is really for long-term care in terms of, we want to prevent you from having a bacterial infection. And once you get into the hospital, this could improve the outcome and, potentially prevent something like an amputation if that got, if it got infected. The main way this works is that it works on gram-positive bacteria. So in the figure here, gram-positive have that very thick, outer membrane, that cell wall that's made of peptidoglycan that cefazolin basically inhibits. So, even though gram-negative bacteria are considered more dangerous than gram-positive because they can develop resistance, a decent bit faster, this is gram-positive, can still give you a lot of issues. So this, this works on gram-positive bacteria. And then in terms of contraindications, you could just ask about antibiotics, penicillin things. I mean, this acts on a penicillin receptor. So, but yeah, really just allergies or hypersensitivities to cefazolin. Then obviously we're not going to give it because we're just going to make stuff worse. All right, next is diphenhydramine, otherwise known as Benadryl. You see it in the little pink bottle all the time. Just asking people if they need to. Let me accidentally X'd out of the presentation. Let me get back to where I was at. Sorry about that. Yeah, so, it's commonly referred to as Benadryl. It's an antihistamine, so it, when you hear antihistamine, a lot of times you might think it's it's a histamine antagonist, but it's actually an inverse agonist of the H1 receptor. So it's reversing the activity of, histamines at the H1 receptor. One of the things to note is that it can definitely lead to drowsiness, and it can, it can cross the blood-brain barrier because it's fairly lipid soluble. So, and that onset is, most people take it PO, so it's usually, that onset is usually slower. But if you're giving it IVIO, it gets into the bloodstream so fast that you might, it's possible you see some drowsiness, especially if you give it that way. Another note is that this is not, absolutely not a first line of defense for anaphylaxis. It is an antihistamine, but it just does not have the power of affecting histamine release the way epinephrine does. Epinephrine acts on the mast cells that are actually producing the histamine, so it's just, you want to use this for more mild, moderate allergic reactions, things like sneezing, coughing, watering eyes, hives, maybe some wheezing, things like that. So in terms of dosing, the adult dose, 25 to 50 milligrams, which is basically just, 1 or 2 tablets, because that's usually how it comes dosed. And then the peds dose is just 1 mg per kilogram. And then the max is 50, just the adult dose. In terms of contraindications, the only ones are really, allergy, if you're hypersensitive to it, if you've had bad reactions to it in the past, or if you're an infant, less than 3 months old, and even at 3 months old, you want to 3, 4, 5 months old, you want to be a little just careful, because they cannot metabolize this drug quite as well as adults can. So, and then that's usually how it comes. So there's a good chance you'll see this, because it's a household drug. Another good thing to know is just asking them if they've taken some already. And if they have, you might want to hold off on it and just get them to the hospital so you don't overdose them or anything. Next one is famotidine. I think I'm saying that right. That's the structure on the top right, so it kind of has a somewhat of a amino acid like structure. And this is also a very common household drug. You'll usually see it in the bottom right is called Pepsid. Like peptic acid. I mean, this is basically, like it says, it's an acid reducer. This is used for things like GERD or heartburn, chest pain, stuff that has excessive acid production in the stomach that's coming back up. The H2 receptor is found on the parietal cells in the stomach, so the ones, they line the lumen of the stomach, and they basically receive a signal from from histamine producing cells, and they bind to the H2 receptor, which basically causes them to stimulate acid production from a counter transporter. So if we're acting as an antagonist at that point, we're reducing acid production in the stomach. So the indications, chest pain, obviously you really need to, this is definitely pretty low on your differentials list. You're really looking at, for something like chest pain, I want to look at something like a pneumo. I want to look at something like a heart attack, heart failure, stuff like that. But this could, heartburn and GERD and stuff like that can still be, is a very common cause of chest pain. In terms of dosing, once again, I was a little scrapped for resources, but what I was able to find, what it tends to look at is adults. Typically, you're just getting, 20 milligrams IV. You might be able to give them a second dose and bump it up to 40 if it doesn't alleviate them. Then for peds, it's 0.25 mg per kilogram for a max of 40. Once again, at the adult dose. Important to note is getting a history. People might have histories of heartburn. They could tell you if this feels different, if it feels similar, if it's resolved itself, etc. And also, last oral intakes, things that are extremely fatty or extremely acidic can lead to heartburn. So that can, if it's starting after they've had a meal of like spicy wings or something like that, that might lend you to looking at something like heartburn as the cause for the chest pain instead of something more drastic like a heart attack or a SNP. No real contraindications that I was able to find. The only note is just that this is a common household drug, so they might have taken it before, so you kind of just want to ask if they've taken it and then, it didn't really do anything. Maybe give them another dose, or maybe we're looking at a different cause for that chest pain. Next one is ondansetron. Very common household drug, usually referred to as Zofran. It's an antiemetic, anti-nausea, anti-vomiting, anti-vomiting medication. So this is kind of interesting. It works at the 5-HT3 receptor. So it's an antagonist there, which is basically, the serotonin 3 receptor. And it acts as an antagonist in both the medulla, so in the central nervous system, and in the periphery via the vagus nerve. So that vagal response is what kind of causes us to, that's what causes us to vomit. So it acting on both of those helps reduce that signaling. And then I also put, so Zofran is on the left and serotonin is on the right. I kind of just did this for myself to see how the structures held up side by side. They're not super similar, but just wanted to see. For dosing, the overall dose is usually just 4 milligrams, like for adults. For peds, it'll be 0.2 milligrams per kilogram, and usually at a max of 4. You can repeat this every, or I don't think it's every 15 minutes. You can repeat it in 15 minutes if you haven't seen an effect or response or anything. For the routes, you can give it, IV, IO, IM, you can give it orally, and then ODT is just, it's kind of the same thing as PO. It's just a dissolving tablet on the mouth. So it's basically, the same thing. The two main contraindications I was able to find are, obviously an allergy, hypersensitivity. If they've ever had a 5-HT3 antagonist, they probably don't know that, but if they've ever had this, ondansetron before, it's probably the most common one. They could probably tell you if it worked or not. Another big one is called apomorphine, which is basically used in Parkinson's, as I think it's like it's like dopamine-like, so it kind of mimics dopamine signaling in the CNS, and Parkinson's is a dopamine deficiency, but you don't want to give it with apomorphine because it can lead to pretty severe hypotension and eventually a loss of consciousness. So you just want to ask about that, and usually if someone has a history of Parkinson's, your mind will maybe start dinging about if they've got really bad nausea, maybe I should hold off on the ondansetron or else I'm going to tank their blood pressure. And the last one is thiamine, which is basically just vitamin B1. So this is essential for, converting food into energy. It's vitamin B1 is a coenzyme that's used in the breakdown of more complex sugars and proteins into, more simple sugars and some amino acids. So, if you don't have this, you're not doing too hot. But one of the main things that this is used for is alcohol withdrawal. So these people are at risk for developing Wernicke-Korsakoff syndrome, which is basically a vitamin B1 deficiency that can progresses from Wernicke encephalopathy to Korsakoff syndrome, which is aphasia, loss of memory, loss of spatial memory, all sorts of stuff like that, ataxia. So yes. And then indications that I was thinking about, altered mental status, you'd want to start thinking about potentially withdrawal syndromes and or symptoms and things like that. Another one is, I think you just call it beriberi, which is basically, there are two forms. There's the cardiac version, which is called wet, And there's the neurogenic, which is, takes place in the CNS, which is dry. So in the if you have dry beriberi, it is, it's causing stuff like numbness and tingling, neuropathy, neurogenic degeneration that's affecting sensory and probably some motor functions. But for cardiovascular, usually what you see is like heart failure, edema, things like that. So it's possible that this underlying cause of heart failure or edema that we're seeing could be due to a vitamin B1 deficiency. The dose is usually 100 milligrams IV. You give it IV IOIM, and then the only other thing to note really is that you this is a good point to know your history, because there's a good chance that a lot of patients with the deficiency will take a vitamin B1 supplement just daily, just to keep themselves going. They might have Korsakoff syndrome or Wernicke encephalopathy, and so maybe they forgot to take it one day, and that's why they're having these symptoms. There aren't any contraindications, and then I just included some high thiamine foods. You could ask them what their oil intake is. If they remember any of this stuff, they, your brain could maybe start ringing as to maybe you think they have a B1 deficiency, but that's also something that we can't really test for in the field. So anyways, yeah, that's the end of my presentations for the AEMT medications module, and I appreciate you watching. Thanks.